The following podcast is part of a certified educational activity titled ALK Positive Metastatic Non-Small Cell Lung Cancer Care Compass. Taking your best shot first, selecting and sequencing targeted therapy, and teaming up to achieve long-term success. Access the entire activity and complete the post-test at peerview.com/PZK860. Downloadable slides and practice aids are also available.
Welcome to this PeerView educational activity titled ALK-positive non-small cell lung cancer care compass. Taking your best shot first, selecting and sequencing targeted therapy, and teaming up to achieve long-term success. My name is Ben Solomon. I'm a medical oncologist from the Peter MacCallum Cancer Center in Melbourne, Australia. And it's my real pleasure to be joined today by Dr. Todd Bauer, a medical oncologist from Tennessee Oncology in Nashville, Tennessee, together with Miss Mary Grizzard, a nurse practitioner from Tennessee Oncology. Our goals for today are to augment your knowledge about the latest evidence of ALK-targeted therapies in advanced non-small cell lung cancer, to equip you with strategies for incorporating ALK inhibitors into personalized treatment plans for patients with ALK-positive non-small cell lung cancer, and to provide guidance on leveraging team-based approaches to manage adverse events associated with ALK inhibitors. We are really pleased to be partnering with LUNGevity Foundation as part of this educational program, and would like to thank them for their insights and contributions. In modern personalized lung cancer care, it is essential to consider the needs and preferences of patients, provide education and guidance to them, and encourage them as well-informed participants in shared decision-making. LUNGevity is firmly committed to making an impact on increasing the quality of life and survivorship of all people diagnosed with lung cancer by accelerating research into early detection and more effective treatments, as well as providing community support and education for all those affected by the disease. A broad range of resources, including focused ALK patient gateway, are available for patients and their care partners. We'll highlight some of these useful tools in this program, but a full compendium of supplemental resources can be downloaded or ordered directly from LUNGevity for use in your practice. I encourage you to have a look at them and to share them with your patients. So I think to set the stage, let's consider a case. This is a typical case of a new patient that might present to your clinic, a 54-year-old woman who had never smoked, who presents with a history of bone pain, fatigue, and weight loss. She has some investigations that reveal a mass in her lung, as well as multiple liver and bone metastases. She has a scan of her brain, which did not show evidence of brain metastases. A biopsy of her lung was performed, which shows a TTF1 positive adenocarcinoma. And the tumor also tested positive for PD-L1 60%. Now, as you can imagine, the patient is anxious and eager to start treatment as soon as possible. And her primary oncologist has made an initial recommendation of immunotherapy based on the PD-L1 results. Let's keep this case in mind as we review best practices for biomarker testing, and really focus on whether we have sufficient information to start therapy. We'll come back to discuss it later with our panel. And for this discussion on biomarker testing and barriers to personalized care, it's my real pleasure to introduce my friend and colleague, Dr. Todd Bauer. Todd?
Thanks, Ben. I appreciate that introduction, and I'm delighted to be on this call with you and with Mary. I'm looking forward to this session. Just want to do a brief review of biomarker testing and what are some barriers that we see in advanced non-small cell lung cancer. Well, we know that in 2025, we have to do biomarker testing prior to starting treatment to really best treat our patients and get the best treatment picked for them in the first line setting. It's gotten a little bit more difficult over the years as we've added more and more different targets, now needing to look for not just EGFR, ALK, and ROS, but also BREF, NTRK, MET, RET, KRAS, HER2, and NRG1. That's all on top of doing the PD-L1 testing. Guidelines for initial therapy in advanced non-small cell lung cancer, and even in earlier stages of the disease, including patient selection for targeted therapies and deselection for immunotherapies based on these results. The type of testing really does matter. We need to know if it is single gene or multi-gene, if it's DNA, or if there's RNA involved as well. RNA, as it turns out, is a better test to look for gene fusions, but it's a little bit more technically difficult, so not always as reliable to get an answer from it. You have to know what you're looking for in the results, and you have to know the details of those results. So it's not enough just to say, yeah, there's a EGFR mutation. You really need to know which EGFR mutation it is. Similarly, not just an ALK fusion, but which ALK fusion it is. So here's a breakdown of all the different fusions we can see in non-small cell lung cancer. So as we do look at those different genetic alterations in lung cancer, we can see that KRAS and EGFR each make up about 30% of those that we see in lung cancer. But what I really want to drill down on is the EML4 ALK fusions. We see these in about 5% of patients with lung cancer. And you'll note that there are multiple different variants of EML4 ALK, and ALK can fuse with a few other partners as well. The variants play a role in how we guide our patients because they can have different predictive values for how well patients will respond to the ALK inhibitor therapies. Something to keep in mind is that patients who have ALK-positive lung cancer are typically younger and never smoker, and they do almost always have adenocarcinoma. I will point out, though, that smoking is not a protective mechanism, so even patients who have smoked their entire lives can still develop ALK fusions. It's just less common. These can be detected by IHC, FISH, PCR, individual gene testing, or ideally just getting broad-based next-generation sequencing. The other thing that's important to keep in mind about patients with ALK-positive lung cancer is typically about a third of them, or as quoted, 24 to 42% of patients with ALK-rearranged non-small cell lung cancer will have brain metastases present at the time of diagnosis. And if they are still alive at 3 years, nearly 60% of patients will develop brain metastases. And so we need to look at that so we can better guide our patients and pick treatments for them. So there are still gaps, though. As much as we'd like to believe that we do everything 100% right 100% of the time, we don't. However, we do know that we aren't perfect, and gaps still do persist in our abilities and our efforts to look for these fusions and mutations in patients. There was a real-world study evaluating biomarker testing and targeted therapy in metastatic non-small cell lung cancer in a community oncology setting from 2015 to 2020. One biomarker test was received by 89% of patients with metastatic non-small cell lung cancer. Now, that means that 10% of patients didn't get any testing done. 46.6% received single gene and NGS-based testing, 34% single gene testing only, and 8.2% NGS-based testing only. Testing increased for ALK from 45% up to 78% after the approval of ALK-targeted therapies, BRAF from 20% to 68%, EGFR from 20 up to 78%, NTRK 35 up to 56, and ROS1 from 30 to 74. Targeted therapy was used in 62% of patients with a positive biomarker test. Now, there could be some other reasons that they weren't put on targeted therapies, but it would certainly be hopeful that we can get a higher percentage of our patients to be treated with these targeted therapies. So we still do have these gaps, and part of our hope today is that we can close some of those gaps and increase testing and education of our patients. And speaking of, when I'm talking about this with patients, I often go down a rabbit hole. So Mary does a lot of the talking with the patients about these and has some good pointers for us. Mary?
So I think in talking with patients, what's important is using plain language. You've got to make sure that you're using the same terms so that the patient knows exactly what's going on and what the expectations are. So use plain language. Shorter is typically better. A lot of times they're trying to jot notes down and you don't know which words they're going to cling to and go home and Google search. So you want to be sure that you're using plain language. Shorter is better. And then use visuals when you can. Most of us can learn a little bit easier with some sort of visuals. So if you have any visuals on hand that you can use to help educate them, I think that's a really good way to communicate with patients. Some good examples of some visuals. These are some tools that LUNGevity has put together that will help kind of navigate and guide discussions with patients. I know commonly our patients are saying, "What am I not asking?" And so this is a great resource that will kind of help them navigate what questions to ask so that they go home feeling just better educated and that they have a good understanding of what's going on and that they know everything that we know at the time. And then deciding on the treatments, this is a nice checklist so that they can keep up with exactly what's going on, what their diagnosis is, and kind of next steps and where they are in the process. And then here is a QR code that you can scan as a great resource that'll provide those so that your patients can have them on hand.
Great. Thanks, Mary. That's super helpful. I really want to take a pause right now and have the three of us talk about what challenges we see in our day-to-day practice and what makes this tough to do and what makes it easier to do. So let's start with some challenges and then we can talk about the opportunities. Dr. Solomon, when you think through talking to patients about it, what are the biggest issues that rise for you when you're having these discussions?
Yeah, thanks, Todd, and thanks, Mary. Yeah, I think you both raised some really interesting and important points. So the conversation with the patients and the importance of waiting for biomarker testing, I think is critical for the patient to understand. But also, I think it creates an onus on us as oncologists to make sure that we get those results to patients in the quickest possible time. And there is a lot of variation in the types of testing that are done, the sort of turnaround times, and I think for each of us working in our different sort of settings, it really is important to try to sort of optimize that as best we can. And that involves talking to our respiratory physicians and interventional pulmonologists who do the biopsies and pathologists and molecular pathology pathologists to get the results back. So I think that's that's something that we can all sort of work together to improve.
Yeah, I think it's from my standpoint, really over the past 10 years, there's been a huge shift in the availability and the ease with which we're able to get these. It's not a challenge necessarily anymore about getting it paid for. It's just remembering to order the test, which is nice. Remembering to look at the results of the test when it comes back. And I really think the biggest issue now is helping patients to understand what those results mean. Because if it's challenging for those of us who went to school for 30 years to figure out, it can be challenging for everybody. So I think that those are the biggest challenges I see now. Mary, do you have any other points?
I think just kind of how it was mentioned that the timing it takes to get these results back. And so I think it's really important to just communicate with the patients and be sure that we're letting them know information as we get it so that they are as comforted as possible and kind of decrease their level of anxiety with new diagnosis.
Right. And if we think through ways to get better, Ben, you talked about the communication between the proceduralists who are doing the biopsy and the pathologist who are reporting it out. I think that's great. And one thing that has helped us a lot have been some molecular tumor boards, which were really able, I think one good thing that COVID brought along was everybody's comfort level of doing Zoom meetings where you can sit and literally be on opposite sides of the globe and have a meeting. as we're doing now. So that's pretty exciting for our patients.
Yeah, I think that's a great point, Todd, and I think you showed that pie chart with the sort of large number of different mutations and rearrangements that we can identify in lung cancer patients, and it's no longer simple. And I think it is important to sort of draw on those resources, particularly when a clinician may be confronted with a mutation or a gene rearrangement they've not had the opportunity to treat before, and to sort of draw on expertise from the broader community. And similarly, I think for patients, the sort of the resources that are available through LUNGevity, some of the other patient groups such as ALK positive and various other groups, are really important and helpful when trying to understand what these molecular alterations mean and implications for treatment. Right. So let's briefly return back to our case. And I think we heard that the patient had a biopsy. We worked out the histology. We got a PD-L1 result back. And I guess despite the anxiety to get started with treatment, I think it's clear from Todd's presentation that we really don't have enough information to start treatment. We really do need to wait for the molecular testing results to come back. So the results have come back now, and the next generation sequencing was done on this patient with both DNA and RNA sequencing, and an EML4 ALK translocation was identified. So I guess this brings a discussion which we'll explore now about what first-line therapy should we recommend for this patient. So let's talk about the results from the various clinical trials that we've got and how this factors in. And I guess stepping back for a minute, when we're choosing first-line therapy for ALK-positive lung cancer, really for any type of cancer, there are various factors that we need to consider, to weigh up and balance, and really to discuss with the patient. And these factors include efficacy of the treatment, safety, toxicity, tolerability, quality of life, the cost of the treatment, whether reimbursement is available, how familiar the physician is, but probably most importantly, the patient preference. And it's important we consider all these factors. I'd like to focus initially on efficacy data with the various ALK inhibitors we have, and look both at systemic efficacy, but also CNS efficacy, because as Todd described earlier, the brain is an important and frequent site of metastasis in patients with ALK-positive lung cancer. So we're fortunate that we have a variety of different ALK inhibitors. We've got 6 FDA-approved ALK inhibitors that are available, beginning with a first-generation inhibitor, crizotinib, extending through several second-generation inhibitors, and the third-generation inhibitor, lorlatinib. And what these newer drugs have in common is that they're more potent against ALK than crizotinib, the first-generation inhibitor. They cover a broader spectrum of mutations which cause resistance to some of the earlier generation inhibitors, and they're better at getting into the brain. I think it's important to reflect, though, on where we started with ALK-targeted therapy, and that's with crizotinib. We saw in the phase 1 study that we did with crizotinib that most patients with ALK gene rearrangements have reductions in tumor size with crizotinib. And in a phase 3 study comparing crizotinib to first-line chemotherapy, there was a clear benefit for crizotinib with a hazard ratio of 0.45 and a median progression-free survival of around 11 months. So this really established first-line therapy with an ALK inhibitor as preferred treatment over chemotherapy for newly diagnosed ALK-positive lung cancer patients. But we've seen advances since then. Ceritinib was one of the first second-generation inhibitors, and in this trial where ceritinib was compared with chemotherapy, the median progression-free survival was 16 months compared with the 11 months or so with crizotinib. This did come at the expense of additional toxicities, including nausea and diarrhea, which interestingly turned out to be manageable when using a lower dose together with taking the tablets with food. But we've seen even better results with some of the later second-generation inhibitors. These are long-term results from the ALEX trial, which compared alectinib not to chemotherapy, but to crizotinib. And as you can see from the progression-free survival curves shown here, there was a dramatic improvement with a hazard ratio of 0.43 and a median progression-free survival of 34 months with alectinib compared to just over 10 months with crizotinib. The overall survival data are also shown here with median overall survival not reached at 5 years. And this speaks to how these drugs really do alter the natural history of the disease. If we look at results with brigatinib, we see similar results. This is a study a phase 3 study, which compared brigatinib to crizotinib. The median progression-free survival was around 24 months. And again, you can see impressive overall survival results. And similarly with another second-generation inhibitor, ensatinib, the median progression-free survival when compared in a trial where ensatinib was compared to crizotinib was 25 months. Again, pointing to the significant improvements over crizotinib with newer generation inhibitors. Unfortunately, though, even with these drugs as effective as they are, we do see resistance develop, and there are multiple different mechanisms through which resistance can develop. This can be due to progression in the brain, because often there are issues with CNS penetration to varying degrees with these drugs, or can be due to intrinsic resistance within the tumors, and this can be due to ALK-independent pathways, which occur through activation of bypass mechanisms such as MET amplification, or through ALK-dependent resistance, which is typically mediated by mutations in the ALK kinase, which cause resistance to the various ALK inhibitors. Importantly, also, this can be mediated by histologic transformation, which includes transformation to squamous histology or even to small cell histology. Probably the best characterized mechanism of resistance is through secondary mutations in the ALK kinase. And what's really interesting is that the mechanism of, or the nature of these resistance mutations is different depending on which ALK kinase inhibitor was used. We see, for example, differences in the pattern of resistance in patients progressing on crizotinib compared to patients progressing on second-generation inhibitors. In patients progressing on second-generation inhibitors, we see ALK resistance mutations occurring more frequently. And a particularly problematic mutation is the G1202R solvent front mutation, which causes resistance to all the second-generation inhibitors. In this context, lorlatinib, a third-generation ALK inhibitor, was developed. It's got a distinct chemical structure. It's got this macrocyclic compact structure. And what that results in is that, a compound that's very effective at getting across the blood-brain barrier. And also, it's able to bind ALK even in the presence of secondary mutations, including the G1202R, and overcome resistance to second-generation inhibitors. And in a phase 1/2 study that Todd and I were both involved in, we saw impressive responses in patients who had multiple prior ALK inhibitors who received lorlatinib. This is a cohort of patients who had 2 or 3 prior ALK inhibitors, so a very heavily pretreated cohort. And in this group of patients, there was a objective response rate of around 40%, with median progression-free survival of around 7 months, and a confirmed intracranial objective response rate of around 50%. Speaking to the activity in this heavily treated population. But this also raised the question about whether this was the best place to use lorlatinib, and whether we could get better results if it was used earlier in treatment and in the first-line setting. And this provided the rationale for the CROWN study. The CROWN study was a phase 3 study in which patients with newly diagnosed ALK-positive non-small cell lung cancer were randomized to treatment either with lorlatinib, given at a dose of 100 milligrams daily, or to crizotinib at 250 milligrams twice daily, which was then the standard of care. Importantly, the study started prior to results of the ALEX study with alectinib, and hence the standard of care. Hence, crizotinib was the control arm for the study. The primary endpoint for the study was progression-free survival, and there were multiple secondary endpoints, including intracranial activity. And I think a really great thing about this study was there was a lot of lot of attention to looking at the brain with serial MRI scans at the time of each disease reassessment. So we really learned a lot about the activity of this drug in the brain. So these were the updated results of the CROWN study after follow-up of just over 5 years. So lorlatinib compared to crizotinib resulted in an improvement in progression-free survival with a hazard ratio of 0.19. But I think what was really remarkable was the 5-year progression-free survival rate. 60% of patients were free of disease progression at 5 years with lorlatinib, compared to only 8% with crizotinib. And these results are unprecedented in ALK-positive lung cancer, and really, to my knowledge, to any targeted therapy in lung cancer. Benefit was seen across all subgroups looked at, including patients with and without brain metastases, and was also seen regardless of ethnic origin, sex, age, or smoking status. Looking more closely at patients with brain metastases and without brain metastases, you can see large benefits across both populations. Benefit was seen both in patients with baseline brain metastases and without baseline brain metastases. And looking more closely at activity in the brain, in patients with measurable brain metastases at baseline, 92% of these patients had intracranial responses, of which 58% were intracranial complete responses. And this really speaks to the activity of lorlatinib in the brain. I think another important assessment in this study was time to intracranial progression. We heard earlier that brain metastases are frequent at the time of diagnosis in patients with ALK-positive non-small cell lung cancer, and develop cumulatively over time. And we see that is exactly the case in patients with treated with crizotinib, where we see steady progression in the brain with an increase in size of existing brain metastases or development of new metastases. And we see that this is markedly attenuated with lorlatinib, with 92% of patients being free of intracranial progression at 5 years. And I think it's even more remarkable when we look at patients with and without brain metastases. In patients with brain metastases at baseline, we see that there's again a steady progression in the brain in patients treated with crizotinib. And in contrast, there's improvement in patients treated with lorlatinib with a hazard ratio of 0.03. And that's a hazard ratio, not a p-value. And in patients without brain metastases at baseline, again with crizotinib, we see steady progression in the brain, whereas in the patients treated with lorlatinib, of 114 patients, only 4 patients had intracranial progression events. And this really speaks to the ability of lorlatinib not only to delay progression of existing brain metastases, but to prevent development of new brain metastases. We do have some insights into resistance based on circulating tumor DNA assessments at baseline and at the time of progression. Still very early days with lorlatinib, but what's interesting is, in contrast to crizotinib, where we see ALK resistance mutations, both single and compound, we really haven't identified any ALK mutations in lorlatinib. And this really does speak to the ability of lorlatinib to shut down ALK resistance mutations as a mechanism of resistance. And I think this is analogous to what osimertinib does for EGFR T790M in EGFR mutation positive non-small cell lung cancer. We don't yet have overall survival results from we don't have mature, I should say, overall survival results from the CROWN study, and follow-up is ongoing. We do have some insights from the phase 2 study from a relatively small cohort of patients, of only 27 patients treated with first-line lorlatinib, where the 5-year overall survival was 76%. But again, I think this speaks to the effect of these drugs in modifying the natural history of this disease. There are newer ALK inhibitors in development. One such compound is NVL-655. This compound is, again, a very compact molecule with very good CNS penetration, and it's able to target both single and compound mutations in ALK. Compound mutations are described as a frequent mechanism of resistance to sequential therapy with second and third generation inhibitors. And the study is ongoing, but we have initial results which show activity of NVL-655 in patients with ALK-positive non-small cell lung cancer, including patients who have received prior treatment with lorlatinib. And I think this is an exciting new compound, and we await updated results from this trial. So let's return to this case as just to briefly recap: a 54-year-old woman who had never smoked with a lung primary with multiple liver and bone metastases, no brain metastases. She has a EML4 ALK rearrangement detected on NGS. So I'll sort of discuss this with Todd and Mary, perhaps starting with Todd. So Todd, this lady comes to your clinic at Tennessee Oncology how do you approach the discussion? You've got the NGS report in front of you that shows an ALK gene rearrangement. What factors do you sort of discuss with the patient, and how does this how do you weigh up the different options available?
Yeah, I think it's certainly not that ever having a cancer conversation is quote unquote fun, but it's reassuring to be able to sit down with the patient with this information in hand and say, hey, look, I now know not just where your cancer started, but more why your cancer started. And we have some really good options to treat it. I do kind of nerd out a little bit and walk them through some of the history of treating ALK positive lung cancer. Not necessarily going slide by slide through it, but just share with them that we had this drug that was, I mean, total game changer, but we've gotten newer versions that are better. And ultimately at this point, based on that 5-year Crown data update, I really do discuss lorlatinib as the first line treatment of choice with my patients and explain the importance of it to treat any brain mets that are there or to prevent any brain mets that have not yet developed, but otherwise statistically would likely do so. We'll cover it in a little bit, but one part of the conversation also is with the caregiver and family, talking to them about the side effects to be made aware of and to look for. And those are the main points of it, I think. Again, when we go through the toxicity slides here in a little bit, we'll talk some more about it. But if they have any underlying chronic health issues that may make them more likely to develop side effects from lorlatinib, we talk about that and what other options we may have as well, though.
And Mary, so this must be a lot of information for patients to take in. They've just learned that they have lung cancer. Now they they're being told that their pathology shows this gene that they've never heard of being identified in their tumor. How do you sort of approach that discussion with patients?
It's important that our patients know that we've been just taking the time to find out as much as we can about their cancer. And that's why we've been running all the tests so that we can find out what the best treatment for them is, because we want them to know that they're our number one priority and that we want to find the best treatment that's catered to their cancer so they can have the best quality of life with the lowest amount of toxicities.
Thanks, Mary. So Todd, you sort of mentioned lorlatinib because of the clear standout with efficacy. This patient didn't have brain metastases. How do brain metastases factor into your thinking about choice of therapy? Would that impact what you do? Would you consider and how do you place radiotherapy into the discussion as well in a patient who presents with brain metastases?
That's a great question, Ben. And I think that so first, if they don't have brain metastasis, that's great. And my thought behind that is I really don't want them to have brain metastasis. So that's where I use lorlatinib in the first line setting with that logic in mind. Now, if they do have brain metastases already, I will have a pretty significant discussion with them about the role for radiotherapy to try and control those. Having said that, and even though SRS is certainly better than whole brain radiation for those Mets, long-term toxicity from even SRS does add up. And so if I think we have an opportunity to treat the patients without radiation and rely just on lorlatinib, I feel very comfortable doing that. I will typically get an MRI again after about a month on lorlatinib to ensure that we're starting to see some shrinkage in those brain mets. And if they have active edema or certainly anything more aggressive than just a few incidentally discovered brain mets, that's where the role for radiation may come in. But I mean, lorlatinib, when it works, we start to see the effects on the cancer shrinkage, usually within a few weeks. So I feel like I'm not sure I gain a lot by radiating somebody's brain if I can just put them on lorlatinib.
Yeah, no, good points. I guess something that we're sort of starting to see more is on our molecular pathology report or our sequencing report, we might get some additional information about the tumor, things like P53 mutations or what type of variant that is. I know at least in the sort of earlier days with ALK and with the earlier generation inhibitors, things like variant 3 of EML4 ALK was considered to have a less favorable prognosis. How did these alterations impact on your choice of ALK inhibitor?
I think I'm still probably using it more to help guide the discussion with the patient about my expectation on their response. And correct me if I'm wrong on this, but I don't think we have data yet suggesting that a particular ALK inhibitor is better for this variant or that variant. But certainly if they have a P53 co-mutation, my enthusiasm for expectation might be tempered a little bit by that. So it does help me guide the discussion with the patient in my tenor and tone.
Yeah, I think that's exactly right. Although these have been described as potential negative prognostic factors with the newer generation inhibitors, we see benefits across the different compounds. We'll continue with this case. So in the end, this patient was prescribed lorlatinib, Todd, as you suggested, and she had an excellent response to treatment at all her sites of disease on imaging. Now, she did develop a couple of side effects that we'll talk about, one of which was hypercholesterolemia. But I think an important other toxicity was that after about 12 weeks of treatment, she complained of fogginess in her thinking, difficulty concentrating, and having trouble completing tasks that she needed to do at work. So I guess these in terms of sort of impacts on patients' quality of life and their ability to sort of to function as they would, these are very important factors to address. So with that in mind, let's have a discussion about how we can manage toxicities to improve quality of life. And I'll hand back over to you, Todd, for this.
Great. Thanks, Ben. I do want to talk about the adverse events and ways to improve quality of life, because in this blessing of having a drug that people can be on for a long time, they can have a long time to develop side effects. So when we think about the selection of which first-line drug we're going to use, of course, the efficacy is important. And I think that I feel comfortable that lorlatinib is probably the most potent ALK inhibitor we have right now. But also the side effects, because there's been much discussion about the side effects of lorlatinib and how to manage it. Now, just like any drug, it has its unique side effect profile, but it just looks different than the other ALK inhibitors. So when we think about alectinib, we're all pretty aware of the liver toxicity and constipation, fatigue, and myalgias that we can see. Brigatinib's main issue, once we solved for the pneumonitis and got better at the dose escalation with that, diarrhea, fatigue, and nausea. So again, these are kind of common TKI side effects. Suritinib also with the diarrhea, nausea, and abdominal pain. But here you look at lorlatinib, and it's different, right? So what are the most common things we see with lorlatinib? Well, hypercholesterolemia is almost universal. 80 to 90% of people will get that. The things people complain about are not GI stuff. It's swelling and neuropathy. There's a weight gain that is a separate side effect than just the edema itself. And then this cognitive effect that we see with lorlatinib that is a pretty unique side effect. And it was described different ways through all the different trials. And I think a lot of people kind of got scared off by that. But really, it honestly just looks a little bit like what we described chemofog to be when patients have been on any sort of cytotoxic, that they just describe a slowed mentation or just less sharp is probably the best way to describe it. There can be some mood effects as well. Depression can pop up in these patients. So it's important to talk through all of those. Now, so these are When we look at the ones that really impact our patient, I mentioned that the hypercholesterolemia is almost universal. It really is. If you don't treat it, the cholesterol will rise pretty high. I had a patient on the phase 1 study who didn't want to start a statin until his cholesterol got to about 550. And then I kindly asked him to start the statin or find something else to treat his lung cancer. And he did start the statin and it went down almost immediately. The weight gain is becoming a more prominent issue. About 2/3 of patients can have a grade 3 weight gain. So that's 20% of body weight growing, which I think we worry so much about weight loss in most of our patients that this is kind of a change of thought process. And of course, with liver function testing, we need to watch that on lorlatinib as well. Here's the interesting thing about this, though. If you look across the studies, and again, this is cross-trial comparison, so it's really just a point of reference. Looking at the number of patients who had adverse events and who had to reduce the drug and then come off of the drug for alectinib, brigatinib, and lorlatinib from the respective studies, we see that lorlatinib does have everybody gets side effects, 100% of patients. And 23% of people had to be dose reduced, but that's pretty consistent with the brigatinib numbers and not too much worse than the alectinib. But what's important is that the numbers in treatment discontinuation. There's really no increased number of patients that had to be discontinued from lorlatinib. And the way that I kind of think through those numbers is lorlatinib does tend to be a more hands-on medicine when I'm first dosing it and starting it in a patient. But once we lower the dose and patients are doing better with it, they can tolerate it and stay on the medicine without great difficulty. So when we're talking through these side effects, Mary does a great job of talking to the patients and their families about them. Mary, can you kind of talk us through how you have that conversation?
Sure. So I think what's important is education. Be sure your patients know what to expect and their caregivers are involved, because as providers, we're only seeing these patients for like a tiny bit of time in their day. So when you involve the caregivers, that gives you a bigger picture. They're going to be the ones to pick up on changes, to communicate that with providers, because the key is early intervention. We want to monitor for changes. The caregivers can help with that, and then just prompt supportive care. And typically, in some instances, tolerability guided dose modifications and reductions may allow the patients to tolerate the drug better.
Yeah. Thanks, Mary. So there are some unique side effects with lorlatinib. When we looked at lorlatinib versus crizotinib in the CROWN trial, we saw a clear instance of hypercholesterolemia and edema being in most of the patients. There's a little bit of diarrhea, but not too much and not too bad. The other thing you'll notice that I like to call out is the weight increase, where we did see pretty significant weight gain in about 2/3 of the patients. 23% of patients did require dose reduction, and temporary pauses in 62% of patients, but only 11% of patients did require that dose interruption, as we talked about earlier. Now, the way that these side effects start and end is pretty interesting. So you'll see that the hypercholesterolemia, any grade hypercholesterolemia, starts very early, typically within a few weeks of starting the drug. Left unchecked, by month 6, 7, or 8, you can see that go to a grade 3 or greater hypercholesterolemia. But the thing to notice is that the grade 3 hypercholesterolemia ends pretty quickly when appropriate treatment is started. Now, we are not cardiologists, so we don't manage this to get it under 200. If we keep people even at a grade 1 cholesterol level, that should be okay. Same is true for the triglycerides. The next thing we see develop is the edema. And again, that starts typically at about month 2 or 3 and can last over a year in this case. But again, the grade 3 edema is really just short-lived with just a very short number of patients and very short period of time. Weight gain starts later and stays longer than any of the other side effects. Again, it's a little bit more difficult to manage. Those CNS side effects crop up also about month 4 to 5 and can last for a few months until they are appropriately treated. And then the peripheral neuropathy, as we end up with a lot of our cancer medicines, does develop after about 4 months. and can last indefinitely as well, though the grade 3 neuropathies all were short-lived. Now, an important thing to know is that lorlatinib can be dose-reduced safely and without any impact on the efficacy of the drug. This was actually Dr. Solomon's article that he was published, and also presented at ESMO a few years ago, that reducing the drug did not lead to increased progression viscerally or in the brain. So the drugs can be safely reduced. Now, of course, with those cholesterol levels, we were pretty worried about what we were going to see with signs of cardiac side effects. You'll note that in the CROWN study, when looking at any patients with cardiovascular adverse events, lorlatinib and crizotinib had 28%, both of them. And in patients who developed hypercholesterolemia at baseline or who developed it during the study, the side effects were, any grade toxicities, cardiovascular events rather, were lower in lorlatinib than crizotinib. All that to say that though there is elevated cholesterol, it does not predict cardiovascular events in our patients. When we drill down into the hypercholesterolemia and hyperlipidemia, we see that most patients do develop increased lipids and increased triglycerides, 108 out of 149 with the cholesterol and 99 out of 149 with the triglycerides. Most of these patients are managed with con meds alone, and most of those side effects most of the cholesterol does resolve with the addition of a statin. Now, Mary, we talk about treating the statins or using them differently. How do we do this with our patients?
Well, typically we let our patients know ahead of time that most likely they're going to need a statin. It's not something that should be surprising to them. It's not alarming. It's just something that we're going to manage going forward. So this is where it's really important that the choice and dosage of the statin, because of the CYP3 interactions, typically we start our patients on Crestor, and it manages their cholesterol well.
One of the other issues is this problem with weight gain, and we'll see that 23% of patients did have grade 3 or greater weight gain, which is a 20% increase in body weight. One of my current patients on this, our firefighter, he was actually pretty excited about the weight gain for a while because he was just getting back up to his pre-cancer weight, where he had been losing weight without knowing it. So there's a little bit of weight gain that's probably okay. It's important to remember that baseline body weight did not influence subsequent body weight or subsequent weight gain. And it does not increase over time, meaning people who are going to get the weight gain start to see it early. Most patients were managed with diet and exercise alone without medical intervention or dose interruption.
But like Dr. Bauer said, this is where you want to pull other resources, diet, nutrition. So lifestyle modifications, refer to a nutritionalist. We have lots of local programs that are for specifically patients with cancer that help them, find an exercise program that they can tolerate and feel good about. So exercise recommendations should be personalized and just really encourage the patients to live a healthy lifestyle.
Yeah, I think the other thing that we will probably be hearing more about in this world is the role of GLP-1 agonists. There was recently just a small case series, I think 4 or 5 patients maybe, that I believe it was Christina Besvina published a couple weeks ago, looking at the role for these drugs in controlling weight gain on lorlatinib. Now, the CNS adverse events were interesting in that 63 or 43% of patients reported them. Most of them were grade 1 or 2. A lot of these were described as a little bit of depression, a little bit of slowed thought process. For most patients, no pharmacological intervention was required. Dose reduction could be used to help with these events. 60% of them did resolve, and only 3% of patients had permanent discontinuation based on CNS adverse events.
Again, like Dr. Bauer said, it's really important that the patients and caregivers know that with a dose hold or interruption, sometimes a reduction, that these side effects do resolve back to baseline. Because I think the CNS effects are probably what's the scariest for most patients. When we're thinking about CNS toxicities, it's very important that the caregiver is involved because they're the ones that are going to pick up on it's not so much I feel sad, but are they going to the grandkids' baseball game? Are they doing the things that they enjoy in life? Or are they having a little depression? So you really want to just ask the questions to try to get to the root of, what's really going on and what day-to-day life looks like.
Thank you.
And this slide just kind of shows just in general toxicities. And you always want to see how bothersome a side effect is to the patient. And then you're going to do a dose pause, let them resolve back to baseline, and then kind of continue the conversation. Does it warrant a dose reduction, or do you resume at the same dose? And again, it starts at 100 milligrams. The first dose reduction would be by 25 to 75 milligrams, followed by, if they need a further reduction, 50 milligrams.
Well, Luke, Dr. Solomon, back in.
Yeah, thanks. Thanks so much, Todd and Mary. So let's go back to our case to talk through some of the practical aspects of what you've just raised. So our patient was started on 100 milligrams of lorlatinib. She had an excellent response to treatment after 12 weeks. But as we heard, these patients can stay on therapy for 3, 4, 5 years, even longer. So I think toxicity management is a really important area that we probably need to work hard at doing, so our patients can get the benefit from these therapies. So the hypercholesterolemia we discussed, this is almost universal. And as Mary mentioned, the patient was started on rosuvastatin or Crestor with good control of her cholesterol. But I guess I'd be keen to sort of talk a bit further about some of these CNS side effects and our practical approach to how we manage them. So I think, Mary, you mentioned the importance of early detection and intervention, and also about involving caregivers in sort of monitoring for toxicity. How do you sort of approach your conversation about CNS toxicities with patients?
I think, kind of like I mentioned before, it's asking the questions like, what does day-to-day life look like? It's not specifically, do they feel sad? It's just, what does a typical day look like? I try to ask questions to get them talking so that I can get a better picture of like day-to-day life, and if they're have good quality of life, and if they're enjoying activities that they enjoyed prior.
To that point, did find that it was impacting on her. The difficulty concentrating was impacting on her ability to do her tasks at work, but also sort of remembering things around her family schedule and so on. So would you, how do you sort of approach the treatment in terms of continuing treatment or discontinuing? And you talked about dose reduction earlier on.
We tend to try and let the patient settle into the dose that they're on for a month or two before we start reducing it. But if somebody's comes back and continually says, hey, look, I'm just not as sharp as I need to be or want to be, we then go through your data about dose reduction and still maintaining efficacy to make the patients feel more comfortable with that reduction, unless it's very significant from a depression or anxiety standpoint. I typically just reduce the dose without holding it and just drop them from 100 down to 75. And usually that does the trick. If they're really feeling out of sorts, though, we can hold it, and usually within a week or two, they're back to baseline. We can resume at the lower dose.
Yeah, I'm pretty similar. I sort of must admit I tend to sort of interrupt dose until patients are back to their baseline. And I will always reduce dose rather than resuming at the same dose. And I think the data you showed about dose reductions and efficacy is pretty reassuring in that regard. And again, another question, Todd and Mary, when do you sort of engage other, I guess, members of our multidisciplinary team, people like psychologists or psychiatry in this management?
I think pretty early. If we get outside of one or two SSRIs, I usually run out of options in my own brain. So I try and get help on board pretty early with this because, again, I think it's really important to quality of life. The mental fogginess and depression. So usually, if I can't get it knocked out within a month, I will send them to somebody else.
Yeah, no, I think that's important to be aware of. But I tend to find that most of the time with the interruption and dose reduction, that tends to sort of get around the issue. Now, we might just touch on some of the other toxicities. I think there was a sort of good discussion about weight gain and how difficult it can be to manage. What about edema? Do you have practical tips for how patients should manage edema?
I think we tend to try diuretics. They don't typically make a huge difference in this patient population, unfortunately. And it really comes down to lifestyle modification. So compression stockings and elevation of feet as much as they can. Those are the mainstays.
Yeah. And I think it is sort of go back to what Mary was saying about the importance of early detection and early intervention. So I think it's important to, when we're planning follow-up with these patients, to have frequent follow-ups with patients, discussions with their caregivers. So what does that look like in your practice, Todd and Mary?
I think we tend to see people for, I would say, monthly for the first 6 months to a year. And after that, we may start spacing them out a little bit. But I think that during that first year, it's a lot of hands-on time with our patients.
Yeah, and I think what we've also seen is that it's probably the first 3 or 4 months where most of the sort of work with toxicity management happens, and then patients sort of settle down into a routine, and it becomes pretty sort of straightforward after that. All right, I think that's been a great discussion, and I think to summarize, I think the key points are, firstly, the importance of molecular testing, and this is key to personalized medicine, and in the setting of ALK rearrangements, super important to identify because it does direct first-line therapy. In terms of the choices of therapies, we've got a number of great options, second generation and third generation ALK inhibitors. But I think the new data from the CROWN study with the 5-year update really does show that there does seem to be a difference in efficacy with really unprecedented results seen with lorlatinib compared with the other inhibitors. But really, I think as healthcare professionals, it really is important for us to work with patients and their families with learning about and managing toxicities, so that these patients can get the benefits in terms of long-term disease control. And with that, I'd really like to thank you, Todd, and you, Mary, for this great discussion.
Thank you very much, Ben. It was a pleasure to join you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, LUNGevity Foundation. This activity is supported by an educational grant from Pfizer. To access all materials for this activity, visit peerview.com/PZK860.